Welcome to the Parent Doctor podcast, where adults who are parents come to learn, lead with love, and grow. Hello, and welcome back to the Parent Doctor podcast. I'm your host, Dr. Marissa Caudill, and in today's episode, I'm going to be talking to you all about bipolar disorder. Before we get to that, though, I would like to remind you all that this podcast is really something I'm passionate about. I want to be able to reach as many parents as possible. As a child psychiatrist who has committed herself to empowering parents to help reduce teen depression and anxiety, I think that our missions are aligned. I think most parents want to reduce teen depression and anxiety too. And I would love it if you could support me in that mission by liking, reviewing, and subscribing to this podcast so as many parents as possible can hear about it. So take a moment to do that now if you haven't already, please. And then I also want to let you know about the free resources that I offer. If you go to theparentdoctor.com, you can sign up for a newsletter that I send out every Wednesday. If you don't want more email in your email inbox, no worries. You can also sign up for a free book club I do that's once a month. I just presented yesterday on a book called Brainstorm by Dr. Dan Siegel. He is a child and adolescent psychiatrist as well who trained at UCLA and works at UCLA. He was one of my mentors and teachers. And this book is all about adolescent brain development. When you sign up for the book club, you'll get an email inviting you to the private Facebook group, which is where all of the live broadcasts for the past episodes, and I've done 6 so far, about the books are there, and all of the PDFs that I make for each book to help you have an actionable summary of the book is also there. So this is a unique book club. You don't have to read the books. I've chosen all of the books for 2024, and I plan to continue this into 2025. I want this to be a resource, again, that gets to as many parents as possible. You can pick and choose which books are of interest to you. And please share that information with your friends. You can go to www.theparentdoctor.com/book club if you want to sign up. All right, so enough of that. Let's get into bipolar disorder. As I mentioned in previous episodes, this first season of the podcast, I just want to focus on the top reasons over my years in practice that parents have brought their kids to see me, a child psychiatrist. Bipolar disorder is unfortunately one of those. Thankfully, though, bipolar disorder in its, true form is extremely rare. It's about 1% of the population and fewer than 1% of young people. The typical age of onset for bipolar disorder does tend to be in the late teens or early 20s. So it's not uncommon across the lifespan for a person to first present with bipolar disorder during this period of time. I've thought a lot about how I want to present this. I don't want to go through kind of the diagnostic criteria. I think that's kind of boring for all of you. You can go search for diagnostic statistical manual criteria for bipolar disorder if you're worried about yourself or your child and whether you have bipolar disorder. But basically, here's what you need to know. Bipolar disorder is a mood disorder, and it's characterized by both periods of depression, but also periods of either hypomania or mania. Now, what does that mean? Well, hypomania is generally a period of time where a person has a lot more energy than usual, a decreased need for sleep, so typically needing 3 or 4 hours less baseline sleep than usual. And then along with that, they have other symptoms. But typically with hypomania, none of these are so severe that they're really going to derail your life. Often with hypomania, people really like these periods of time. They're more productive. They may feel like this is their true best self, but it's short-lived typically. So this is times when people are more creative, they're more productive, they're more talkative, more social, more outgoing, more risk-taking, and just generally feeling usually very good, although sometimes it can be associated also with more prominent irritability. In contrast, full mania is characterized by more debilitating elevated mood. So this is either a euphoric or an irritable mood, along with a decreased need for sleep, increase in goal-directed activity. Often you'll see people who are exhibiting increased interest in love relationships or believing that someone's in love with them, kind of an erotic delusion, or more interest in seeking sexual pleasure and dangerous sexual behaviors. Often there's an increase in seeking drug-related highs. There can be an increase in spending that leads people to really accrue a lot of debt. And so mania, although in the moment it might feel good for the person who's going through it, it often is very debilitating. It can lead to job loss, relationship loss. It's really tough to be experiencing. The hard thing about bipolar disorder is that these episodes can come out of nowhere. And sometimes they're triggered by stress, drug use, sleep changes, jet lag, those kinds of things. And sometimes they just happen. Classically, people who have bipolar disorder cycle, and the usual cycle is first an up cycle with hypomania or mania, followed by a down cycle of depression. And it's in that in-between time when people can be in what's called a mixed state, where they have features of both depression and mania, that their mental health is really at the most fragile, and that is when a person with bipolar has the highest risk for suicidal behaviors. There's an author named Kay Redfield Jamison who's written several books about her experience with bipolar disorder. I recommend those books if you want to kind of get a perspective taking. And I think it's worth me talking about a few of the young people that I've treated. And thankfully, although I've been in practice for nearly 20 years, I haven't treated that many young people with true bipolar disorder. And I think that's an important thing to keep in mind. So if you have a kid who has big emotions, big behaviors, if you're worried, is this bipolar disorder? I want you to take away from this episode the fact that it's probably not. Most psychiatrists who have experience are going to try to exclude and find other reasons to explain this behavior, because most likely it's something else, usually substance induced. But we have to know that, again, 1% or less of the population has true bipolar disorder. It's not that it couldn't be that, but it's usually something else. And there's a doctor named Gabrielle Carlson, Gay Carlson. She is at SUNY University. She trained at UCLA. She has written so many papers. I think she has over 280 papers about childhood bipolar disorder. And it used to be thought that kids who have huge emotion, big mood swings, that those are kids who are going to grow up and become bipolar. But it actually turns out that that is not true most of the time. Most kids who have huge mood swings and difficulty controlling their emotions are at increased risk for depression, but not at increased risk for bipolar disorder. And this is good news, because bipolar disorder is a much more severe and difficult to treat illness than depression, even though depression stinks too. But it also is good news because it helps us as child psychiatrists to know that we don't have to go all in on the heavy-duty medications that we use to treat bipolar disorder in kids who are exhibiting severe mood symptoms that don't meet criteria for bipolar disorder. I'm reading a book right now, which has been around a long time. Many of you may have read it already, called The Body Keeps the Score. And in the beginning third of this book, the author talks about the astounding numbers of prescriptions of antipsychotic medications in children that have been given over the last 20 years. And I think that this is important for us to keep in mind. If you have a child who's been diagnosed with bipolar disorder, I want you to really talk to your provider about, is it really bipolar disorder? Is my child needing these medications? Have they really helped them? Again, the medications for bipolar disorder can really help, and I'll talk about some stories about that and my experience with that in a minute. But they are often fraught with negative side effects, some of which are permanent and irreversible. And I think we have to be very mindful of making a diagnosis of bipolar disorder and starting those kinds of medications in kids until we've excluded all of their options for what it could be and all of the treatment strategies that we could use to try to support a child who's having significant mood symptoms. All right, so let's talk a little bit about some stories. The first patient I ever treated and diagnosed with bipolar disorder came to me when he was young. I think he was probably between 11 and 12. I don't want to reveal his name. We'll just call him Jack. And so he came in with his mother, and the story, I believe, if I'm recalling correctly, this was many years ago, was that the biological father had some severe mental illness. I don't know if it was schizophrenia or bipolar disorder or schizoaffective disorder, but any of those could increase an offspring's risk of having bipolar disorder. So that was, when I think about the biopsychosocial model, when I'm interviewing a patient and their family, the tick was there to think biologically this kid could have a risk factor for bipolar disorder. There was no substance use. There was no significant recent trauma or stress. And the story that the parent was giving me about what this child was experiencing was very consistent with bipolar disorder. He was having very discrete episodes of significant decreased need for sleep, where he would be up all night in goal-directed activity. He's a kid, right? So he wasn't doing the things that manic adults typically do, stalking someone he was in love with or spending tons of money, but he was obsessing about an interest, which was to create, I think, a game. And then there was this persistent, irritable pressure on the parents to buy the things that he needed for the game and to create the game. And he wanted everyone to do this. And it was really unreasonable and really getting in the way of his functioning with friends, with family, and at school. And so we talked it through, all the history. There's a structured diagnostic interview that is usually used when trying to discern whether this is depression, bipolar disorder, or something else. And I saw this person in a clinic where I was learning how to do that. So I did that interview, reviewed it in a team meeting, and we ended up treating this young man as bipolar, starting him on lithium. Lithium is one of the most effective medications to treat bipolar disorder and mania, but it does have some risks to kidney function and thyroid function. So it requires that the person taking it take it as prescribed, that they know about the warnings and risks of toxicity, and that they get regular blood work and checkups with their doctor to make sure that everything's going okay. But I'm happy to report that he did very, very well on that medication for the years that I treated him. And from what I know, I'm still somewhat in touch with the family. I think that he's doing very well now also in his young adulthood. So that's a success story. Other cases of bipolar disorder in young people that I saw were more challenging. Again, this is so hard, right? In almost all cases, the young people that I treated were really smart, really successful young people who then developed mania followed by depression. And it was usually in late high school years or early college years, which are a time in your life when you're supposed to be launching, right? So it's really hard to accept that. And that mania and depression, even though it's very disabling when it happens, it isn't permanent. So it lasts for however long it lasts. Even if you don't treat it, it lasts for weeks or months. And eventually you reach a new norm again. And then it becomes this question in this young person's mind and their family's mind, like, was it real? Did that really happen? Was it really as bad as I thought it was? And the natural tendency is to want to assume it didn't really happen or it wasn't as bad as you remember it being. And the challenge really with young people is to get them to be compliant with taking their medications. Again, because when there's a diagnosis of bipolar disorder, the medications are hard to take. Lithium can cause side effects like acne, weight gain, slow thinking, slow cognition. You have to get blood work regularly. It's not fun to take those medications, especially if you're like a young 20-something person or an older teenager. That's not something you want to be doing. And then once you're feeling better, you have to stay on it in order to prevent future episodes of mania. And that's no fun either, because once you're feeling better, you want to believe that you're going to be fine. And here's where, I can tell you my training as a psychiatrist and all of the data, but I think our data may be somewhat skewed. We see the people for whom recurrent episodes of mania happen, but I do think there are also people for whom those episodes don't happen. The classic thing is that it happens pretty regularly, and the more often it happens, the more likely the brain is to have this happen. It's called kindling. So if someone has an episode of mania and a few months later another episode, then they're considered rapid cycling, and that's harder to treat. So the idea is that the more often someone's having episodes of mania followed by depression, the more aggressive you want to be in your treatment, the more consistent they have to be with their medications in order to prevent future episodes from happening, and the poorer the prognosis. But that said, when I was in training, I also had an older woman patient in the geriatric ward who was in her 70s, and she had had one episode of mania in her 40s after treatment for breast cancer that may have been precipitated by steroid use. So she got treatment, she was on lithium for a while, and then she got off of it, and then she was fine for 3 decades and ran the family business. And then again, with no stimulus, she had another episode of mania with psychosis. She believed things weren't true. I mean, this woman was hiding in the bushes naked outside her house before police brought her in. She was really out of sorts. And so that's a very atypical presentation, but there are people who have this type of trajectory with their illness as well, where they might not need to be on lithium for 30 years. Because if she were going to be on medication, if we had a crystal ball, right, and at 40, we could tell her okay, well, you're not going to have another episode for 30 years, then really the risks for her of staying on the lithium versus getting off of it would have been preferable to be off of it, right? The problem is none of us have that crystal ball. We can't know what someone's natural course is going to be. And so the best recommendation that we can give as a psychiatrist to someone who definitely has bipolar disorder is to stay on that medication long term. And, in this episode, talking to all of you who are parents who may have kids with bipolar disorder or young adults with bipolar disorder, I just want you to know it's normal for your young child, young adult, to not want to stay on these medications and to not really believe the diagnosis. That's the normal course. And I think You can't get too angry at them. You just have to be sympathetic and understand that it's going to be a rocky road, because until they have a few episodes and they can really believe and understand that, yes, this is an illness that I am unfortunately dealing with, then it's going to be hard for them to be consistent and compliant with their medications. Another important aspect to consider with bipolar, I talked about this earlier, I think in my second episode about vaping, is that, and this is true for many of the people I've treated with bipolar disorder, vaping wax, so that's the concentrated form of marijuana, puts people at a very increased risk for developing mania. And again, I've only treated, probably like a dozen or so, maybe 10 to 20 people who were young people diagnosed with bipolar disorder under my care. And in more than half of those cases, their recovery was hindered by the use of wax and by the use of marijuana and other drugs. And it's really a curse, right? Because again, with the mania, there's all this risk-taking, risk-seeking, dopamine-seeking activity, much of which does lead to drug use. But then that drug use triggers the brain to be manic again, or to be harder to come down from a manic episode. So all of the medications that we use to treat mania are kind of sedating medications, right? You're taking a brain that's overactive, that's firing on all cylinders and trying to slow it down to a normal level. But in the process of doing that, of applying those brakes, there's often a lot of negative side effects of feeling slow, of feeling cognitively dull, of feeling tired. And then in addition to lithium, we sometimes use mood stabilizers like Depakote or other anti-seizure medications. Again, these have the same problem, the same side effects. And then often we also use medications in a class called antipsychotics. And these, again, work to block dopamine signaling, and they also can have problems with weight gain, development of diabetes, which, again, as you know, can be permanent, and a potential risk for something called tardive dyskinesia, which is a movement disorder that may not go away even when you stop medication. And that can include involuntary movements, lip smacking, grimacing, writhing movements of the body, those kinds of things. You may have seen people on the streets or out and about who have those kinds of involuntary movements, and that's scary. But of course, when you have a true diagnosis of bipolar disorder, that in and of itself is so debilitating that the potential risk of tardive dyskinesia, in my mind, doesn't outweigh the benefit to you if it can get you back to a place of stable mood where you're not depressed and you're not manic, so that you can hopefully function again. So that's kind of my summary of bipolar disorder. This isn't a super long episode today, but I want to interview parents and patients who have bipolar disorder in season 2. So if you or your child have ever experienced diagnosis of bipolar disorder, bipolar 1, which is the type that has full-blown manias, or bipolar 2, which is the type that has hypomanias, I would love to talk to you. So please email me at hello@theparentdoctor.com if you'd be open to that, and we can get you on the schedule for a future podcast recording. I'm hoping to talk to a family member of mine too, who I'm pretty sure was diagnosed as bipolar in their teens and now is, I think, over 40 and doing very well. And I'm curious about kind of what the course was there, because again, I was far apart in age from this person. I heard about it like through family members. I don't really know how it all went down, but I know there was a couple psychiatric hospitalizations, medications. And I just find it kind of interesting that not everyone follows the classical course of like multiple episodes throughout that lifetime. Some people have, like my older patient that I told you about, one episode and then decades, and then they don't have another episode. But that's certainly not the normal course, and I don't want to give extra hope to people who may be diagnosed with bipolar disorder thinking that that's the case. More often than not, when someone has a diagnosis of bipolar disorder, this is a true mental illness. This is a true way that the brain is just not functioning the way it should be, sadly. And it's treatable, which is good, but it is something that can be very debilitating. And even with treatment, we can't 100% prevent future episodes of mania or depression. What else should I talk about? Well, another thing you should know is that commonly depression is the first mood symptom for a person who later turns out to have bipolar disorder. But again, major depressive disorder is more than tenfold more common than bipolar disorder. But what will sometimes happen is a person will be diagnosed with depression and started on an antidepressant, and that will trigger a hypomania or a mania. Again, that's not the usual course of bipolar disorder. Bipolar disorder is usually mania followed by depression. Some people can't tolerate antidepressants and may experience a hypomania or mania in response to an antidepressant. That seems to be probably different than a bipolar presentation, a person with mania who didn't have any substances on board. That may be a brain that is just susceptible to a manic response to antidepressants. But it still means that we can't treat that person's depression with classical antidepressants. And in that case, what we often use is a medication called Lamictal, which can be very helpful and is generally pretty well tolerated. All right, so that was not the most linear episode I've ever given you guys, but hopefully it was helpful. Next time, I'm going to talk about psychosis and schizophrenia. In today's show notes, I will give you some resources. Again, because bipolar disorder is really, it sucks. It's a really hard illness to cope with if you have it, and if you are the loved one or parent of a person who has it. I strongly recommend seeking support, and one wonderful resource for that support is NAMI, National Alliance of Mental Illness. They have local support groups all over the country, and if you go to NAMI.org, you can find some of those. Knowing that you're not alone when you have a rare condition is extremely powerful. And having a group of people who can know what it's like for you is also extremely powerful. There are also a couple movies that I really like. One was with Anne Hathaway, and I will put that and some book recommendations in my show notes for today, along with the NAMI resource and other resources that would be helpful to you as parents. I hope to see you next time. Thanks so much for tuning in. Take care.